Only mode.
Hello and welcome to Bellscope's online webinar entitled Oral Cancer Screening for Today's Population. Join the fight. My name is Joanne Jones and I'm a registered dental hygienist and president of RDH Connection, and I'm very happy to be your host today for this 1-hour webinar. We will have a Q&A opportunity at the end. If there are any questions, I'll be happy to answer them at that time. So let's get started on what we're going to talk about today. So learning objectives are to understand the changing behaviors of oral cancer due to the human papillomavirus in today's population. And secondly, to recognize high-risk anatomical areas and those subtle life-saving signs and symptoms that may accompany HPV oropharyngeal cancer. And third, to compare and contrast the value of direct tissue fluorescence designed to reveal what may have not been visible with white light examination. And for you as a dental practice, really to be equipped today to meet the needs of the population that are sitting in our chair. That is so vitally important, and we're really happy to provide you with some clinical resources and a whole list of educational materials, and I'm super excited to talk about the launch of a new program that is something that has never been offered before, so stay tuned. So who is today's oral cancer profile? The Oral Cancer Foundation has done much to elevate awareness within the general population and also within our professional community to make those aware of the fact that today's oral cancer profile is not what we would expect, not what we would have identified at high risk, say, 5 years ago, 10 years ago, 20 years ago, or even as recent as a year or two. When we look at today's profile, we're seeing that there is a current trend that is showing a shocking increase in young individuals who, for the most part, are non-smokers and non-drinkers. This current situation is now being called an epidemic by those in the treatment and research communities. Consider this oral cancer victim. Beautiful 46-year-old fitness trainer, mother of 3, and a very loving wife. In my lectures, I do speak about the whole story, which really hit our family hard a couple of years ago. My cousin Bonnie, pictured here, was diagnosed with late-stage HPV-16 oropharyngeal cancer in the midst of me being ready to present my research to a national conference on oral cancer. It was a hard, crushing blow to all of us. We had every hope that she would survive, as this type of cancer statistically is more treatable and more survivable than non-HPV related. Unfortunately, and it was a very sad day for all of us, on December 6, 2012, just actually 16 months after her preliminary diagnosis, that Bonnie passed away. So what was once maybe a passion of mine is now my mission to get this message out and to make sure I equip you as a dental professional with all of the information that we really need to know to save lives. There is so much happening in the oral cancer world. I'm just astonished every time I go and look at Facebook or I go into my emails. I'm getting stories and accounts of people that are discovering oral cancer, that are discovering oral cancer in people that they least expected. So again, we have an opportunity. We are on the front lines. So let's look at a snapshot of oral cancer, the incidence and the trends. I know that we have a North American-wide audience today, so we have our U.S. colleagues as well as our Canadians. So I'm going to take a look first at some of the U.S. facts. 43,000 plus Americans will be diagnosed with oral cancer this year. Worldwide, the problem is much greater, with actually new cases exceeding 640,000 annually. The fastest growing segment, and this is what's critical to you and I, the fastest growing segment of the oral cancer population are HPV, human papillomavirus 16 positive, and it's happening in young non-smokers, and this is what is spiraling out of control. One person will die every hour of every single day. Oral cancer does not take holidays. It does not take time off. It does not take weekends away. 24/7, 364 days a year, someone will die every hour of oral cancer. Tobacco use in all of its forms and alcohol are still major risk factors for oral cancer, and that's very important for us to recognize and remember when we are screening for oral cancer. There are several signs and symptoms, and I'm going to go over these with you specifically in the webinar. I also would like to draw your attention to the PDF that is available for download, and this would make a great fact sheet to be able to print off and keep in your reception area to elevate awareness of your dental patients. So if you go to the, even if you want to Google Oral Cancer Facts 2014, OCF, Oral Cancer Foundation, Oral Cancer Facts 2014, you'll be able to get this free download. So let's look at what the Centers for Disease Control updated in 2013. Their previous update suggested that there were approximately 20 million Americans. Now they're saying approximately 79 million Americans are currently infected with the human papillomavirus. Another 14 million people become newly infected each year. HPV is so common that at least 50% of sexually active men and women get it at some point in their lifetime. So that's what we're dealing with. This is one of the, if not the, fastest growing sexually transmitted infections in the entire world. In Canada, oral cancer is the 9th most common cancer in males and the 14th most common in females, and again ranking 6th worldwide. The number of new cases and deaths due to oral cancer is 3 times higher than cervical cancer and double the rates of liver cancer. Overall, 5-year survival rates for oral cancer, the statistic here is 63%. I've seen it as low as 50%, again depending on the stage of discovery. Whereas we compare that to cervical cancer being a 5-year survival rate of 75%. So unfortunately, oral cancer continues to be the forgotten disease and lags behind. The percent distribution of new cases, when we look at 9th overall, we must keep in mind that prostate, colorectal, and lung cancer actually accumulate to 51%. So oral cancer is 2.9%, but it is actually 9th overall. And for females, breast cancer, lung cancer, and colorectal, again, 51%. Oral is 1.5% or 14th overall. So 75% of Canadians will be affected, and that statistic refers to, with the Canadian population, the suggestion that 75% of Canadians will have an HPV infection in their lifetime. So you can once again see how rampant the distribution of this sexually transmitted infection actually is. When we look at some of the statistics that have been gathered by the National Cancer Registries, and these statistics come from the largest national data registries that we have available in the United States. And what they have indicated is HPV positive oropharyngeal cancers have increased by 225%. In their incidence and for HPV negative, actually these cancers have declined by 50% from 1988 to 2004. So if we take a look here on your screen, the yellow line depicted on top here is overall incidence of oropharyngeal cancer. And this again is between 1988 to 2004. If we look at HPV negative, or those cases that are going to have most likely the etiologic factors of smoking and alcohol as the primary risk factor, we're going to see that this gray line actually has dropped as indicated by over 50%. But if we look at the blue line supporting HPV positive oropharyngeal incidence, we can see that it is actually increasing at the 225% mark. If we were able to predict where this is going to go, by today, 10 years later, 2014 and almost into 2015, we would see that blue line continuing to spiral upward. So very interesting to look at the evidence and the research supporting this escalation. And this, again, is why the HPV link with oral cancer and oropharyngeal cancer is being described as an epidemic. So let's take a moment here to understand the connectivity. What is the connection between HPV and oral cancer? There are more than 120 types of the virus, and only a few are high-risk type, particularly HPV 16 and 18. And over 90% of HPV-positive oral cancers are HPV 16 positive. HPV is associated with nearly all cases of pre-invasive and invasive cervical neoplasia. So here we have, through sexual behaviors, the transmission mode from the cervix to the oral cavity. HPV 6, 11, 16, and 18 are related to a venereal wart and present in the oral cavity as something called condyloma acuminatum, which we're going to have a look at in a moment. 9 strains, and this is growing, have been identified as having the potential to become cancer-causing or oncogenic. Persistent infection with a high-risk subtype is a risk factor for this oncogenic transformation. So let's take a little bit of a look at the mechanism and a brief look, an overview at the histopathology. It's important to note that the human papillomavirus has an affinity or a liking for lymphoid tissues, particularly tonsillar tissues. The virus's DNA integrates into the nucleus of healthy cells. Once it does this successfully, it's able to produce oncogenic proteins or cancer-causing proteins. And you'll read a lot in the studies and information about E6 and E7. And there are actually a lot of interesting studies looking at seropositivity, blood plasma identification of E6 and E7 even prior to the diagnosis of oropharyngeal HPV-related cancer. Now, what does E6 and E7 do? They're very dangerous to us because they bind to what we want to see in surplus, and that is our tumor suppressor proteins, particularly P53 and PRB. P53 is a NPRB. They're tumor suppressor proteins, meaning that they will suppress a tumor formation. When we look at what's happening with E6 and E7, they actually tend to, with the human papillomavirus, silence P53. This is not a good thing because our body's immune system then fails and doesn't have that opportunity to really function at its best. Let's take a look next at what the visual clinical manifestation is of HPV, particularly in the oral cavity. We will talk about oropharyngeal recognition as well, but again, due to visual acuity and a more, or lack of, and a more posterior placement, I want to first look at what is visible in the oral cavity. So the first picture here is condyloma acuminatum, sexually transmitted, most likely caused by the strains 6, 11, 16, and 18. These are like a cluster, but they can appear as a single lesion as well. They're multiple, they're papillary, they're slightly raised, they're attached with a broad or sessile base, they're painless, persistent, and we're going to see them most often in young males, particularly, or young adults, particularly males. We might see this on the lips, the tongue, the soft palate, and we'll look at clinical presence, clinical manifestation of some of these other areas. How is it treated? By local excision, sometimes laser ablation, but we must remember that reinoculation is going to be common amongst sexual partners if the virus is active. Now, upon contact of mucosal tissues anywhere in the body, the lesion may not manifest itself right away. It may take 3 to 12 months before it actually manifests itself clinically. And again, because it's so small, it is easy to miss. So I just want to take a look at some of these lesions. On the tongue here, we can see this lesion that is pictured on the lateral border. The lateral border is a very high-risk area for HPV and non-HPV related oral cancer. It looks like, if you think of a cauliflower, and if you look at all of these lesions, have that distinctive kind of marking like a cauliflower. We can also see on the uvula here where there is a cauliflower marking, and in the tonsillar area itself. This is on the palate. And then here is another lesion, an HPV lesion on the gingival tissues. This is one of the reasons why it's so important to dry the gingival tissues when you have a look at this area, because as you can imagine, when we've got presence of saliva and we've got the overhead light, we sometimes have the saliva reflecting the light, and we don't actually see these small lesions, and we can easily miss it. The last picture here is quite an outbreak of condyloma acuminatum in the oral cavity, and you can see that there are clusters as well as single nodules. So what are the subtle life-saving symptoms? What can we as a dental professional not ever afford to ignore? Hoarseness, or the change in your patient's voice. If there is a change, make sure you ask about that. Have they had a cold? Is there a reason for this change in voice? What about a persistent sore throat or a persistent throat infection? And something in particular that is not responding to antibiotics is really critical, because if it is a viral origin, it could be that the antibiotic prescription may actually be addressing the secondary symptoms, but it may not be getting rid of the infection entirely, and for that reason the throat infection is going to recur. And this was one of the subtle things that happened in the story of my cousin, where she had a couple of continual sore throat infections that weren't being addressed with antibiotics. Also, pain when swallowing or difficulty swallowing. Or if your patient says to you, you know, I find that I can't eat certain things like granola or anything kind of crunchy because I'm finding it gets caught in my throat and I almost feel like something is continually caught there. That is so important. It's so subtle that a lot of times somebody would not even bring it to your attention. Also, pain when chewing, continual lymphadenopathy or enlarged nodes, and we'll talk a little bit further about this. And of course, a non-healing oral lesion is so important. Bleeding in the mouth or the throat, or that taste. Sometimes our patient will say they have a taste of metal in their mouth. That warrants further investigation. If it's not something related to restorative or leaching, it could be the presence of bleeding in the throat that they maybe aren't aware of. Unilateral ear pain. That's important too, because often what we'll see is asymmetry in the tonsillar area or an infection on one side, not normally on both, and then we're going to have corresponding possibly ear pain. And then again, this is so significant, a lump in the throat or a feeling that something is stuck. And it often feels like a little popcorn shell or a kernel of corn. Unexplained weight loss. If your patient has not entered into a new dietary regime, or they haven't been really ill with another type of illness and they've lost more than 10 pounds, that is something that warrants further investigation. Slurred speech, or the inability to articulate. If that has changed, it could be related to a tumor being based at or being located at the posterior base of the tongue, such as with Michael Douglas. He had a walnut-sized HPV-positive tumor at the posterior base of the tongue, and that can, of course, start to affect speech as it grows larger. And then the last one, as I mentioned, is asymmetry in the tonsillar area. So let's look next at some of the high-risk anatomical areas. And I do want to make a differentiation between HPV positive and non-HPV. HPV positive is going to have more of an occurrence in the posterior areas, more in the oropharyngeal areas. And if we look at oropharyngeal areas, this comprises the back, or comprises the back of the throat, the posterior areas of the tongue, the base of the tongue, the palatal areas, the uvula, the palatine tonsils, and also the pillars. So think posterior when you think about HPV positive high-risk sites. When we look at non-HPV, we're looking at the anterior segment of the mouth, where we're looking at the anterior area of the tongue, lateral borders, dorsum, ventral surface. We're looking at the floor of the mouth, and also the palatal tissues. Those are the areas that are most high risk for non-HPV related oral cancer. The drawing pictured on your screen is an overview of a number of the nodes that we would be examining when we do our extraoral or our head and neck examination. And I have pictured them in a systematic order. Number 1 is the submental, number 2 are the submandibular, dropping down to the neck are number 3, number 4 are the supraclavicular, number 5 are at the base of the occipital bone, number 6 are the posterior auricular, and number 7 are the anterior auricular. They're all important because we've got afferent and efferent vessel drainage that happens from the head and neck, and then also from the thoracic cavity, from the breast area, from the gastroesophageal area, from the intestinal area, all drain into these nodes. So the nodes tell us a tremendous amount of information. So it's very important that we palpate these areas well. One of the things that I have learned through my journey with my cousin and also through oral medicine pathologists is the palpation technique for the submandibular nodes. It's important to do your cursory rolling stroke to determine if there is any palpable node, but it's also important to use unilateral palpation. Get your patient's head positioned down, and as we're talking about this, try it on yourself, where you're going to take one hand, position it under the angle of the mandible with a firm pressure, and then place your chin right down to your chest, and then your ear over to your shoulder on the same side as you are palpating. This will allow you to actually get in at a deeper level and be able to identify a node at an earlier stage. When we look at lymphadenopathy considerations, it's important if we do find something to recognize in the broadest of terms what may be infection-related and what may be neoplasia-related. Often infection-related, they're soft, they're normally a little bit tender, it could be painful, and the patient's going to be aware of an underlying infection. They're movable, they're not attached. So it's a very different feeling from one that may be related to abnormal tissue development or may be related to cancer growth. So think of a blueberry, and I've pictured that on the screen here to help remind you, or a pea, something that is soft, is movable. On the other side, when we look at the neoplasia or cancer-related, it's firm. It's usually not symptomatic, so your patient often will have no awareness, and it's going to be fixed to the underlying structure. And it's going to feel, again, very much like a stone or a little pebble. It's going to have quite a different feeling than the infection-related node. So just take a moment to think about that and the differences between infection-related and neoplasia-related. The next area that we're going to, of course, examine with our oral cancer screening is the 7-step intraoral examination. So we've got, again, a systematic order: lips, labial mucosa, buccal mucosa, the gingival tissues. Again, high risk areas: the tongue, floor of the mouth, oropharyngeal, and palatal tissues. The Canadian Dental Hygienists Association have developed the poster that you see on this particular page. These resources and an online course will be made available in March of 2015. There also are some other wonderful resources which we have included as a download for you, and I'll give you some additional information about that to accompany this webinar. So let's look at high-risk areas. The tongue. First of all, remember what I said. The tongue, sometimes one of the subtle symptoms is if there is tumor development that is impeding the complete movement of the tongue may track to one side. So we want to make sure that when we have our patients stick out their tongue and we look at the dorsum, have them first move it from side to side and look at the movement and make sure there is no restriction. The next thing you want to do is feel that tongue. You want to place an index finger on the dorsum and a corresponding thumb underneath on the ventral surface and slide those fingers down, compressing the tissue, because the first sign may be a hardness or an induration that you won't see until it's much, much further developed and could compromise the health, the future, even the life of your patient. So important to not only look, but make sure you feel. Same thing when we look at the lateral borders. When remember, non-HPV related, we're thinking more anterior, which again is a very, very high risk area. And remembering that abnormal development starts down at the basement membrane. So important for us to feel this area. Look and feel. Make a little hammock out of your 2x2 instead of doing the 2x2 grasp. It makes it better. You get better full protrusion. It's actually a little bit more comfortable for your patient too. So look and feel. And make sure you roll that tongue because you don't want to miss the area between the dorsum and the ventral surface. When you go to the next picture, the third one, you'll see looking at the other side. So important. And then the last but not least is the ventral surface. Again, look and feel. So important. Floor of the mouth. One thing that I want to say here, bimanual palpation. If you're not doing that, 2 fingers inside the mouth, 2 fingers extraoral placement, you are never going to detect an area of induration or swelling because again, the area here is very, very high risk both for non-HPV and HPV related, anterior for non-HPV and going more towards the posterior, again, generally speaking, not in all cases, but generally speaking, for HPV related. So this area is so important to do bimanual palpation and enough compression that when we are palpating the anterior area, we should actually feel our fingers almost touching there. And then last but not least, the visual and tactile palpation of the soft palate, and then examining the entire area of the posterior wall of the throat, the oropharyngeal area, with particular attention to the tonsillar area. So mouth mirror, tongue blade on the back of the tongue. Instruct your patient, take a deep breath in and say, ah. This will raise up the uvula very well so that you can see that whole posterior wall. But there is a problem, and unfortunately we have not made any inroads. We can look all we want with our own eyes. We can do a better job by feeling. That is a critical mandate that we not only look but we feel. We can elevate once more with actually wearing loupes and magnification. When I pose the question to dental professionals and say, is your practice really dedicated to early detection? If you're not wearing loupes for magnification purposes, again, you are going to miss so many of the visible lesions. However, we're forgetting one thing. By the time it becomes visible, and with its close proximity to the lymph nodes, we're overlooking a very critical point, and that is it's often too late. Remember, many times what we see is only the tip of the iceberg, and this is one of the best pictures that I can demonstrate this with, is that there's so much more going on underneath, and because, again, we've got infiltration into the lymph nodes with great ease with the positioning of the oral cavity and its high-risk area just merely because of its anatomical placement, we are looking at a deadly situation. The appropriate stage for discovering intervention is as pictured with the red arrow. That's early dysplasia. That's at the basement membrane. We can do so much. We can save people at this point. By the time it becomes visible, way over here and up here, we have either taken up the whole epithelial space or we have breached that basement membrane, and this has become invasive. Invasive, exactly how it sounds, squamous cell carcinoma, and a lot of times into the later stages depending on the length of time and its access into the lymph node areas. So that is when we find that 1 out of 2 basically will not be alive in 5 years' time. And don't kid yourself. Those that still are alive, that have been in the later stages, have had a quality of life that is compromised beyond physical reason, beyond the way an individual should ever have to live their life. It is heart-wrenching. And if you haven't seen some of the pictures, Google it, go to the Oral Cancer Foundation, look in on their chat forums and see how people are really coping with surviving oral cancer. It is most challenging. The limitations of the clinical oral examination have been addressed by the Journal of the American Dental Association because of this problem, because we're discovering it way too late, and because of the compromised health and well-being of the people that actually are living with oral cancer. So the fact that oral squamous cell carcinomas, and this was determined after a comprehensive literature search, the fact that oral squamous cell carcinomas often are diagnosed at an advanced stage of disease indicates the need for improving the complete oral examination and for developing adjuncts to help detect and diagnose oral mucosal lesions. No one could have said it better, and it was very clearly evident and obvious after the Journal of the American Dental Association looked at the literature review and recognized, hey, we've got a problem here. We're diagnosing way too late. So I would like to introduce you to the Velscope VX, the 2-minute exam that can save your life. This should be in every reception area, and we'd like to give you some tools here to be able to look at some of the abilities of what Velscope can actually do for your practice. So let's look at the technology platform. When we look at how Velscope works, I'm going to give you a quick overview and a quick science lesson. There is a proprietary wavelength, a safe blue excitation light. And if we look at what happens in normal, healthy metabolism of tissue, you probably remember the Krebs cycle. And I know we thought in our youth, when would we ever refer to the Krebs cycle again? Well, here we are, X number of years later, referring to the Krebs cycle. In normal, healthy metabolism, there are certain enzymes that will fluoresce back under this particular wavelength. One of them is called flavin adenine dinucleotide, or FAD. It is in abundance in normal healthy tissue. And we've got collagen cross-links, and we've got an abundance of this enzyme that's here. So we get this apple green glow that comes back to us of normal healthy tissue. And it's a very distinctive apple green color. But when we start to get a disruption of the stromal collagen. In other words, when we get abnormal cellular development, we get breakdown in these cross-links, and we get a lot of congestion happening. And we also get increased vascular flow, more blood flows to the area. So we get a very condensed area that no longer is able to fluoresce. And that enzyme FAD, which is available in abundant amounts with normal healthy metabolism, becomes drastically reduced, and it's no longer able to fluoresce back. So instead of getting this lovely green, apple green glow, we get a very dark area, not a diffuse, watered down area. We get a dark pattern that's well-defined border that stands out as being very different in contrast to the normal healthy tissue around it. So let's look at some of the statistics here first about users. More than 25 million Velscope VX examinations have been performed by over 12,000 dental practitioners in 23 countries. So this is a global technology. It is also backed in by many of the most prestigious dental journals and publications and clinical studies than any other adjunctive device for tissue fluorescence visualization. Velscope has not piggybacked onto any other device. It was a medical device that was used in the cervix, lungs, and the colon, but Velscope is the only one that has a profound depth of clinical studies that back the technology itself. The global market has positioned Velscope as a leader with a recognition from the World Health Organization, which we're all familiar with. In June of 2010, it was awarded as one of the 8 medical devices, and it was the only dental device chosen that would actually impact a global concern, being oral cancer, and would have a positive effect on the impact of oral cancer. So again, congratulatory award to Velscope for being one of such great value to the professional community. So what are we looking for? We're looking at unilateral as opposed to bilateral. presentation, again, because same as where an oral lesion would be, we're not going to see bilateral. First thing we do as a dental professional is if we see something, we right away look to the other side to make sure that we're not seeing something that is symmetrical and is considered normal for that particular client, such as lingual tori, for example. Well demarcated borders, so not that hazy kind of gray diffuse pattern, but a well demarcated border that stands out against the healthy tissue around it. And abnormal patterns that appear out of context and spread across different anatomical structures. So there was a really great clinical study. There have been a number of them, and a couple of them I'm thinking of in particular that have been published more recently by Denise Laurent, that are talking about low-risk populations and how Bellscope, with this particular study that was published in General Dentistry, helped catch 28 lesions, including 5 dysplasias that were missed by the naked eye. One thing I do want to say to this too is often I'll hear, hey, well, what about the false positives? I hear there are a lot of false positives. Remember and make sure you are positioning, as you see on this particular slide, that Bellscope and the technology of direct fluorescence visualization is an adjunctive screening tool. The only true diagnosis is going to be a biopsy. So keep that in mind, that there are 0 false positives because we are not dealing with a diagnostic tool. We are using a screening tool. So bilateral presence is a good thing. We can see back here, you can see some of the vascular areas. We can see some of the vascularity increased in the posterior area, the same as we see visually with our own eyes. This is a normal presentation. We can see bacteria represented here by this orange glow on the back of the tongue. We can also see that Bellscope, direct fluorescence visualization with pigmentation, it absorbs the wavelength. So we see again this identical reflection in the oral cavity. So these are a couple of the principles that are taught when Bellscope is purchased by a practice. They have a wealth of teaching aids and tools, which again is so important to integrate a device into your dental practice with ease and with success. So pigmentation absorbs it. But again, we're never going to be concerned about this because we know this is pigmentation. So not a concern. This was an attendee at one of my lectures. She is holding down her lip, and I thought this was such a great representation of what inflammation looks like. This, as we recognize it, is an aphthous ulcer, and you can see the white fibrin clot here, and the area of inflammation where it is more acute is right around the border. But then as we move away, we can see that it gets more diffuse. If I were to use something called diascopic pressure, which is using the back of the mouth mirror and sweeping across this area, applying pressure with the back of the mouth mirror, I would see that blood flow would move out of the area, and this would actually blanch white under diascopic pressure with Bellscope. That way you would be able to easily determine that this was an inflammatory lesion. But again, as a dental professional, we know that if we see something, if it doesn't need immediate referral for obvious reasons, we know that we reappoint in 14 days if we are unsure of the etiology or if there is a lesion present. When we look at the clinical presentation of Bellscope versus visible white light on the left side of your screen here, we can't really see too much, but under Bellscope, this is a great picture because you can clearly see this well-defined border here that stands out against the regular healthy tissue. When we look at the pathology report, this was actually carcinoma in situ. So again, if we look at this area, this would have been missed, this was picked up. And amazing when you think of the potential to save a life. And I actually just received one of those reports and have it on my Facebook page of a tremendous story of a life that was saved, which wouldn't have been without the help of Bellscope. When we look at dysplasia and oral cancer in this particular picture, this draws our attention. This was later shown on the pathology report to be mild dysplasia, but on the other side we have carcinoma in situ. And again, we would not have seen that with the visible eye. This would have been missed. So when we look at what capabilities we actually have, it is a tremendous adjunct to what may not have been visible with white light examination, to actually be able to see down to the basement membrane where abnormal tissue development starts. This was a very interesting study that got not only the approval for an opportunistic oral cancer screening device, but also by the FDA and Health Canada to determine surgical borders. So follow along with me. We can see this lesion outlined here, a little bit of a leukoerythroplakic lesion here. We've outlined it, or it was outlined in T-blue, to be able to actually identify the borders, the visible borders, and measure it and so forth. If we go to the next picture, and let's go back here for a second. What we would normally do if we were an oral surgeon, we were doing an excisional biopsy, we would take a 10 millimeter clearance around the visible lesion. If we go to the next picture, with Velscope, you can see a clearly defined dark area, which is suggestive of abnormal tissue by the loss of fluorescence. They then outlined the area so we could visually see that with the green. So we could definitely see this posterior area. But when we look up beyond the visible border, there was a much larger area that was actually visible. Then a 10 millimeter clearance was actually taken around the area where there was a loss of fluorescence. So if we look at the excisional biopsy, the red circle depicts what was visible with both white light examination and with Velscope. The green circles identify the areas that were visible with Velscope itself, and the blue areas were not visible with Velscope or with the naked eye. The interesting thing is, in this study, 18 of the 20 patients showed dysplasia or cancer beyond the clinically visible lesion. 50% of the tumors exhibited cancer or dysplasia at or beyond the traditional 10 millimeter surgical margin. So if we had taken that 10 millimeter clearance here, we would have missed this area completely. So again, a reason why Velscope supports complete determination of surgical margins. The other thing that's so important is, hey, what if you see something? How do you then send it off in your referral or your management pathway? So it's so important to be able to have a device that has a seamless transition for you, that you can take a picture right away, so you don't have to have someone else help you, and you basically have that capability with seamless integration. So the camera actually fits right on. This is the Velscope VX custom camera solution and comes with the Velscope VX kit. When we look at the digital camera, there also is an adapter that you can use, and this is what I had used in the past, and there also is SLR capability as well. But this is definitely the easiest way, is with the custom camera solution. So with the management, again, 14 days for observation if we have an unidentified lesion or an identified lesion, and we just want to make sure that it disappears. Again, we are going to make sure that it resolves, and if it doesn't, we are going to refer. Remembering that the only true diagnostic tool is a biopsy. We have included for you, to accompany this webinar and to assist you in integration of this knowledge into your practice, it's our pleasure to be able to provide for download on the Velscope website. There is a download center, and if you go there after listening to the webinar, you'll be able to get this one document here that is a resource listing of a lot of educational and clinical resources related to oral cancer, and more specifically to the HPV profile. The second document is a quick reference guide to oral lesion documentation. And I would also add that Velscope and LED imaging have provided a wealth of other tools for you that are available to you to make, once again, the practice of oral cancer screening a success in your practice. So in conclusion, with the acquired knowledge of risk behaviors, our prevention strategies, and these enhanced screening tools, our profession is strategically positioned to play an integral role in earlier discovery of abnormal lesions, therefore contributing strongly to better treatment outcomes, improved survival rates, and enhanced quality of life for our dental patients. There are costs and risks to a program of action, but they are far less than the long-range risk and cost of comfortable inaction. John F. Kennedy said this, and no one could say it better. It's easy to continue on not making changes. It's a wonderful feeling. if you can save a life, but I cannot explain to you how terrible it is, and I hope you've never had that opportunity to miss a diagnosis. If we have the opportunity with not only our talents and our capabilities, but the use of screening agents to better identify oral cancer in an earlier stage, what is stopping us? Late stage discovery, for some people, life will never be the same. This gentleman has had over 20 surgeries. For some people, like my cousin, life will not be an option. And her 3 beautiful teenage girls are without their mom in a critical time of their life as well. When we look at what the editor said, Damon Adams, Dr. Damon Adams, a colleague of mine, he asked me to write on Viewpoint, and he has made mention of that, about sharing the recent experience in our family. This was in Viewpoint of 2012. And he asked a critical question. He said, is there more heart needed? Why, when I go to a dental convention, do I see so many people lined up for free toothpaste or a new toothbrush? And yet I walk by the booths that have oral cancer screening devices, and there is no lineup. There's only a handful of people. I must say I'm very, very proud and extremely gratified to see that there is a shift happening and there is a change. But that's a call to action. Together we can make a difference. And if you go to the oralcancerfoundation.org, if you scroll down, you'll be as surprised as I was to see my face at the bottom. But that is the RDH campaign. And you can download that sign and take a picture of yourself and print it off and be part of the change. But I want to ask you a question. Where do you go from here as a practice? Knowing what you know and hearing what you've heard about this atypical, new, escalating profile, what changes are you going to make in your practice? Change does take action. So I am absolutely thrilled to be able to have the pleasure of announcing the Join the Fight campaign. The LED imaging is just launching. I believe I may be one of the first to even be able to talk about it. So what an honor and what a privilege. They are actually giving you a free Velscope VX system. So as of today, you can order your system for free. Why? They want you to join in the fight. They want you to join LED in the fight. They know that early detection is the best way to stop any form of cancer. And yes, HPV is very daunting and a bit scary to us, a lot scary to us as dental professionals, but it's really just one more reason to do what we should be doing anyways. Dental practices are uniquely positioned to take the lead in this fight. The program was formed to encourage dental professionals to do early screening and provide you with an incentive of a free Velscope VX enhanced oral assessment system. This is a gift and a retail value of over $2,700, $2,700, not including the taxes. So how the program works, you commit to doing 3 screenings a day. Basically, you're going to identify in your practice 3 people that you are going to screen for oral cancer. The 3-year term is based on 250 working days in a year, so it doesn't include weekends. It's just the days that you would be in practice. All you have to pay for is the asepsis barrier, the VelCap, which ensures infection control and proper quality of imaging. This is $2.50 per patient or $7.50 per day for 3 patients. I hate to do this, but it's literally about the price of a Starbucks coffee. We all know that we enjoy a Starbucks coffee. The monthly cost for consumables would be $156 with potential revenues of over $1,000 per month just for joining the fight. So it not only is an opportunity to save lives, to see more, to identify oral cancer and abnormal changes at the earlier stages, not diagnose, but identify, to be able to screen more effectively, but it also is it can be profitable for your practice. By spotting indications in the early stages, the positive impact on your patients' lives, I wish I could articulate it better for you. The disfiguring, aspect of survivorship of oral cancer, the lack of having proper saliva, the inability to ever sit down and eat a meal again with grace and be able to eat whatever you want to eat is sorely compromised. So what LED is asking you to do, and the only thing they're asking you to do, is notify them of biopsy-confirmed oral disease such as dysplasia or oral cancer so they can track the difference this program is making. That's a small amount of work to do for the generosity that LED imaging is providing to your practice. So I'd like to say to you, I'd like to have a call to action and basically a commitment to look at. It's a new year. It's a new start. You have an opportunity to have a renewed commitment. I love a new year. It's an opportunity to not look back and say should have, could have, would have, but an opportunity to say I can and I am. This is an offer for you to participate. I'm going to leave this up for a moment so that you may write down the information. For more information, please contact, if you are in Canada, Randy Patipko, or and his phone number is there, 519-841-5016, randy.patipko@leddental.com, or our national sales manager, Wayne Reese, National Vice President, Wayne.Reese @leddental.com. So WAYNE.Reese, REES, @leddental.com, 604-889-9912. So remember, you are doing a potentially life-saving exam. This is a non-negotiable part of the exam. Why wouldn't we? We wanted to provide an opportunity for questions if there are any particular questions, and I did see a question regarding the vaccination. And I do often get asked about this question about the HPV vaccination. And at this point in time, the literature, the clinical studies are very, very promising. However, there is not the literature yet to be able to publicize, or publish, I should say, the impact of the HPV vaccination on oral cancer. But it obviously is making huge inroads on cervical cancer. And knowing the transmission of the virus, it definitely is going to be one that I can say with confidence is going to make a positive impact on oropharyngeal cancer, especially in our male population. At the present time, there are two vaccines that are available. The one most widely used is Gardasil. It is called a quadrivalent vaccination, and it actually addresses the strains, the high-risk subtypes that are 6, 11, 16, and 18, and it is available, has been studied for females and males. The clinical studies encompass the age groups of 9 to age 26. However, depending on legislation in your state or in your province, some in the school immunization programs only make it available to females. However, that is quickly starting to change. At the present time, the HPV burden, or the highest incidence of HPV-related cancers are related to cervical cancer. However, they do say by 2020, and many studies to support and back this statement, that HPV oropharyngeal cancer will be the leading HPV cancer in our nation. So again, the vaccination, I'm sure this will become much more widespread as far as its availability in school immunization programs. It is available through your medical practice, but at this point in time, if they are not having it available to both males and females, if you have a young son or you have a young adult male that wishes to get the vaccination, they are going to have to pay for it. Sometimes you can put it under your drug plan, but again, that is applicable to your particular state or province medical legislation or your insurance policy. So again, join the fight for earlier discovery of oral cancer. I'm excited to see what you will be able to do in 2015 with the opportunity to screen for the earlier discovery of oral cancer. Please feel free, follow me on Twitter, on Facebook, email me if you have any questions, jjones@joannejones.com. And I wish you a very happy new year, and thank you very much for joining me today.